Thanks everybody for coming and to this wonderful session. Thank you, Monica. Thank you, Matt. And I'm going to talk about the SIP project. Let's see if this thing works. Yep, awesome. Okay, so for a little bit of context, this project is based in England. And in England, crack cocaine is the main stimulant that's used primarily amongst people who you might perceive as people who use drugs, people who use heroin or whatnot. Methamphetamine use is more confined amongst men who have sex with men, chemsex population. So of course there are other pockets of population who use methamphetamine. Now, engagement with drug services is really low among people who smoke stimulants, and there are a couple of reasons for this. There is absolutely no pharmacotherapy available for stimulant use, particularly in specialist drug treatment services or on the NHS, and stimulant smoking equipment provision is prohibited under UK law. We can give out injecting equipment, but drug treatment services, harm reduction services are not allowed to give out pipes for methamphetamine, crack, etc. So, and also, as you can see here, crack use has been rising in the UK. And the figures in red show people who are only using crack, who are not using heroin. So those people are going to be particularly marginalised from services because they're not going to necessarily be going in to get opiate substitution therapy. So what we did is applied for this grant, National Institute of Health and Care Research, were amazing in funding it, to see if the law needed to be changed. I think you probably all know my perspective on that, but you know, we had to create the evidence to persuade the powers that be. I'm not going to go through the methods, but I'm going to talk more about the findings, but I'm going to, I mean, it was a very rigorous study. It's got a before and after component with control groups, qualitative process evaluation, and we're looking for our impact evaluation at these measures. Reduced pipe sharing, there is an association of pipe sharing with hepatitis C transmission. Secondary outcomes are reduced homemade pipe use, and you'll hear why this is an issue. Ash as a filtration or a suspension device is also an issue, reduced injecting, and I'm highlighting these in red because of the remit of this work around reducing bloodborne viruses. So these issues I'm going to concentrate on and show how they can potentially help to reduce bloodborne viruses, as well as highlighting what I also think is really important around respiratory health. So big thank you to Exchange for Supplies for facilitating this study. We would not have been able to do it without them. They provided all the SIP kits for free. They're hosting the training on their website. I really want to emphasise this is not just about providing pipes. We developed an e-learning module to skill up providers at drug treatment services to enable them to start having conversations with people about their crack use. The knowledge amongst providers is very variable and often not that great. So there's our kit, and you can see them at Exchange Supplies. Okay, so I'm just going to present on the baseline survey findings. We do have the follow-up survey data complete, but it has not yet been fully analysed. So, I mean, this is amazing though. This is 734 people who all have used crack within the last 28 days, and it's quite a unique sample, and I really want to highlight actually that the majority, 66%, did not inject in the last month. And also 38% are not on OST. These people have got absolutely no reason to go into services whatsoever. There's a lot of polydrug use going on, particularly depressants, benzos, heroin, pregabalin, also spice. And 55% use crack every day. And the median use of crack was 21 years, and you had 42% people reporting using crack from 21 to 30 years, so this is a very experienced cohort, and I feel really honoured to have be able to work with this data. So we asked about crack-related symptoms, diagnosis, hospitalisation. We're particularly interested in respiratory issues. And I just want to highlight here, like people can have the slides, but that there was a gender disparity disparity in reported respiratory symptoms. We had about a third of the sample were women, and there's a significant difference there in all of these things. And also to highlight that a quarter of the women reported being hospitalised for pneumonia. Now, I'm really interested in understanding what's going on here, so if anyone wants to talk to me in the break about this, please come and grab me. So, we asked about homemade pipe use. Now, obviously, you know, people can't get crack pipes from services. It doesn't mean they're not going to smoke crack. It means that they're going to make their own pipes, and often these are of unsafe materials. And our qualitative research has really highlighted why. And just to give the example of inhalers, residue, the crack residue or recycle is highly valued by people who use crack. People may scrape it out of inhalers, and I heard over and over and over the story about people scraping it out, seeing visible bits of the inhaler plastic, and then smoking that with the residue. There are a lot of other harms. There are harms associated with use of stainless steel scrubber, for example, as well. And, you know, I can, again, talk to people in more detail about that. So if we're thinking about hepatitis C risk and health, you know, pipe sharing is our primary outcome measure. There is evidence to say that, you know, there's hepatitis C transmission potential through pipe sharing. We had 44% of people in baseline reporting sharing. We're going to hope that that's going to go down in the next one. But, you know, I think what's interesting here is the second quote where the guy talks about getting the cold sore transmission from pipe sharing. But also, I think what's important to emphasise here is the attempts that they made to reduce that happening. People who use crack do care about their health. And in this quote, you know, is quite a poignant example of an unsuccessful attempt, but an attempt nevertheless to protect oneself from getting cold sores. So he talks about burning the pipe, trying to get the cold sore residue off. Now, even if you're sceptical about the hep C transmission potential of sharing, it's irrefutable that injecting is a risk. And what provision of pipes also can do is to reduce injecting. And now what we saw here, which was really interesting, is people transitioning to injecting because of experiencing respiratory harm. Now, you can understand how that's a harm reduction measure. If you are, like you said, this person coughing up blood, difficulty breathing, you know, and you still want to use crack, then okay, that injecting might be safer in terms of respiratory health, but not in terms of other things. We found there was a huge unmet need amongst this population. People felt that there was nowhere to turn. People felt that the services weren't orientated towards them. They didn't feel necessarily able to disclose. They didn't feel they were able to have the conversations they needed. They talked about lack of pharmacotherapy, and they talked about mental health desperation and unmet need. And I think this is a really crucial thing which I want to sort of follow up on. And again, I would invite people to talk to me about that. And we asked people if they felt they needed a mental health assessment in the past 6 months. 60% said yes, and of those, 51% that they said they couldn't get the help. I'm actually surprised that 43% said that they could. I'm like, but you know, anyway. And what I really want to emphasise is that what we're already seeing is amazing results in terms of service engagement. You know, we haven't been able to finalise the impact evaluation, which is a before and after survey, to look at our outcome measures, but our observations, providers, and also this monitoring data is showing enhanced engagement with services. People are walking through the door for the first time. So monitoring data, every time somebody got a SIP kit, they had to fill out a survey, and we asked, is this the first time you have ever been to any drug treatment service? That's a really high bar, right? And 180 people, it was their first time, and they had come in specifically for a pipe. Now that's the tip of the iceberg, because provider interviews, observations, etc., they were talking about seeing hundreds more people coming in through the door. So these may have been people who may not have come in for 10 years, or may have gone to another service a long time ago. And I know I'm sort of on the red zone, but This is again been really important. Providers have talked about people transitioning from injecting to smoking because the pipes are available. Also smoking heroin on the pipes. Now this is really important in terms of the nitazines we are now seeing in the UK drug supply. So that's a potential harm reduction response also. But also importantly, it's opening up conversations. Providers are talking about people coming in to get a pipe and then opening up about really complex health and social problems and actually being referred to support, being referred to bloodborne virus testing, all of these other things. So I just want to wrap it up and say that please come and talk to me if you want to know more. We have published our protocol on this, which has all the methods. But, this is an important study. It's the first in the UK to pilot and evaluate a crack pipe provision program. And I'm really hoping that it's going to inform legislative change. And, that there's already we're seeing huge benefits in terms of engagement with services and hopefully longer term benefits in relation to respiratory health, injecting and these other things. So thank you very much.